I will call the meeting of the Healthy Communities and Environment Committee to order at 11:10. First order of business is roll call.
Powell. Here. Kokendorfer.
Here.
Gershenson.
Here.
Todd.
Here.
Nelson.
Here.
Loops.
Here.
You have a quorum.
We have a quorum, thank you. Let's all stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Are there any corrections to the minutes of the previous meeting from February 24th? If not, we need a motion to approve the minutes. We have a motion by Commissioner Nelson, seconded by Commissioner Gershenson. All in favor signify by saying aye. Aye. Opposed? Motion is carried. We need a motion to approve the agenda. A motion by Commissioner Gershenson and seconded by Commissioner Nelson. All in favor say aye. Aye. Opposed? That motion is carried. The next item is public comment. Is there anyone from the public wishing to speak to this committee? Public comment is closed. We move on to communications. Under communications, to receive and file is the fiscal year 2020 to 2022 contingency report. From the Veteran Service Division, the 2020 County Veteran Service Fund grant application. The last item is from Michigan Department of Health and Human Services Board minutes dated February 18, 2020. A motion to receive and file by Commissioner Nelson, seconded by Commissioner Taub. Any comments or questions? If not, all in favor signify by saying aye. Aye. Opposed? That motion is carried. We move on to our regular agenda item. First item on the agenda is from our Health and Human Services Health Division. Amendment number 1 to the Nurse Education Practice Quality and Retention Registered Nurses in Primary Care Grant. I have a motion by Commissioner Nelson, seconded by Commissioner Taub. Thank you. Welcome.
Thank you. Good morning. Leanne Stafford, Health Officer for the Health Division.
Kathy Forsley, Director of Health and Human Services.
Hi, so this amendment is amendment number 1 to the existing grant where we have nurses from the Wayne State coming in and we're doing preceptors for them for 150 hours. And so what this is this is an additional $20,000 so that our preceptors can go to conferences and trainings.
What's a preceptor?
So a preceptor is someone that trains a nurse. So it's a nurse with usually a BSN or somebody that's got, a number of years of training in nursing. And so they work with them on a one-on-one basis on what they should be looking for and how they should be, working with clients and recording.
Thank you. Commissioner Taub.
Do we do this with Oakland, or do they not have a program?
We also have a agreement with them. I'm not sure how the money is transferred, but we also do that with their nursing students as well.
Okay. And this is only good through June of this year?
That's correct. This additional funding is is June. And so they have identified some trainings, online trainings that they can go to and a couple of conferences that they'll be able to utilize the money with.
Okay. Will we get this next year, or don't you know, this edition?
This is a 4-year grant, so we'll get the funding, but I'm not sure about the additional money. That is only through June of 2020.
Okay, so is there some point in time that you will know that, will they notify you one way or the other?
Yeah, same way like this. They'll say there's extra money available, and they'll offer it to the agencies that have this agreement with them.
But it's
Now,
ongoing.
It is ongoing. The existing grant is ongoing,
Right,
right?
right,
It's just the
right.
additional money may
Okay.
not be available.
So do we work with LPNs as well through the community colleges or not in any programs?
Not at this time.
Are you looking to do anything with them? Because I know the need for either RNs or LPNs is really huge.
We opened up public health nurse one. We opened up a public health nurse one, but what was the qualifications? I don't know if it's LPN though. It's
No, they still have to have a 4-year degree. It
But
just
doesn't
may
have
not,
to be
a
a BSN.
BSN,
So not with LPNs.
So we're not employing any LPNs?
not at this time.
Okay, is there a reason why? We just don't have room for them, or we just have never done it?
Yeah, we've never done it. We believe that the education that the BSN gets in school is really best suited for community public health. It's something we can look at down the road as there are other ideas out there how an LPN could be used.
Okay, thank you. Thank you, Madam Chair.
Commissioner Powell?
The acronyms, what is BSN and LPN? What does those stands for? I know it's nurses, but I just wanna know what it is.
BSN is Bachelor's of Science in Nursing, and the LPN is a licensed practical nurse.
Thank you.
And it really just refers to the different levels of education they have.
Okay, thank you.
Any other questions? We need a roll call.
Powell? Yes. Kokendorfer?
Yes.
Gershenson?
Yes.
Cobb?
Yes.
Nelson?
Yes.
Loops?
Yes.
Motion carries.
Motion is carried. Thank you.
Thank you.
The next item, again, is from your department, the fiscal year 2020 subrecipient agreement between Oakland County and Oakland Livingston Human Services Agency for Women, Infant, and Children. Motion by Commissioner Nelson, seconded by Commissioner Cobb. Thank you.
Thank you. So this is an update to our existing contract with ULSA. Currently, in the past, they have been a contractor, but based on the state audit, the state MDHHS is requiring them to be what's called a subrecipient. And so it basically is the same. We'll review, invoices for actual costs, and they'll be paid the same way. It's just that we had to change the contract language. And so that's what this request is for.
So a housekeeping item.
Correct.
Thank you. Any comments or questions? Roll call, please.
Kokendorfer?
Yes.
Gershenson?
Yes.
Cobb?
Yes.
Nelson?
Yes.
Powell? Yes. Loops?
Yes.
Motion carries.
Motion is carried. Thank you. The last item, Health and Human Services, again, agreement between the County of Oakland and Honor Community Health for integrated health care. I have a motion by Commissioner Nelson, support by Commissioner Gershenson.
Good morning. Leanne Stafford's passing around a small packet of information to support the presentation this morning.
Thank you.
I'd like to thank you for the opportunity to come back and have a formal presentation for the approval of Health 360 and specifically the partnership with Honor Community Health. I was last year here on January 27th, but today I'm back, and with me to help with this presentation is Debbie Brinson, the CEO of Honor Community Health, and Leanne Stafford, the health officer for the health division. And between the three of us, we hope to provide you with some information that would be important to you for approving this project. And also happy to answer all of your questions when the presentation's over. And also we have here other member or staff from Honor and Dr. Hamadi from Honor Community Health and Christine. Cynthia, sorry. I don't know what her title is.
Cynthia Duncanson is our CFO. Dr. Hamadi is our Chief Medical Officer. And George.
George Miller, who you probably all know. He's on the board of directors. They're here to show the support for this project. So I'd like to just briefly go back over some of the reasons why we felt there's a strong need for this program. And when we go back a few years, we really began to see a need in our clinic rooms. Nurses were spending more and more time talking about issues that had nothing to do with the specific reason why they were in our clinic rooms. But there was a lot of social determinants health issues bubbling up. So the things that they were bringing to us were, we need primary care services, we need other services, we need mental health, we need many presented with immediate needs for substance use problems. They were looking somewhere really needing jobs, or they needed better jobs to support their families. They even expressed a need for training in order to get those better jobs. Many talked about not having adequate food shortages in their household, affordable housing. Many expressed that, within the next 30 days, they weren't sure they were going to have a house or a safe environment to live in. They talked about reliable transportation issues, and also there were many that could not pay their utility bills. So this was our beginning, realizing that we're just not able to provide the support we need to when they come to us for clinic services in the health division. So then when we are, the health division also does a lot of work with data collection for our community needs assessment, and we look at a lot of different sources. So we looked at health outcomes by neighborhoods, and of course, Oakland County fares really well with most health indicators until you start drilling down in specific neighborhoods or by specific populations. And then we realize we have a lot of disparities. This map shows you census tracts, and in Pontiac, there are census tracts where the life expectancy is only 66 years of age. In Southfield, there are census tracts where the life expectancy is 72 years of age. Whereas in Troy, just about 10 miles away from these locations, there are census tracts where the life expectancy is as high as 86 years of age. So that's a great disparity, 14 to 20 years, just based on where you live, which is really has to do with social determinants of health. Then we go on to look at the fact that our offices in Pontiac and Southfield happen to be in health professional shortage areas for both primary care and mental health. This is the primary care map, and as you can see, Pontiac and that southeastern little tier of communities is really impacted by a professional shortage area for primary care. Also in these areas, we have 95,000, approximately 515 individuals that are in the low income categories. So if you're in low income, you're probably having either no insurance or the kind of insurance where it's even harder to get primary care providers that will take your insurance. So this is the mental health map for the shortage areas, and as you can see, they're pretty much the same with the exception of some areas around Troy where there's a little difference between these maps. And then when we dive into insurance stats, we have nearly 250,000 people in Oakland County that are either not insured, which is about under 60,000, and uninsured, 60,000 uninsured, 126,000 plus that are on Medicaid, 42,379 individuals enrolled in health insurance marketplace plans. On all of these insurance or non-insurance means it's really going to be difficult to find a provider. Some providers say they take Medicaid, but in reality they may only take a few individuals and then they cut it off and they don't have room for any more Medicaid insured individuals in their practice. So,
Quick question, with the stats on the insurance,
yeah,
is that per individual and does that include children?
it's per individuals and it does include children.
Does,
Yeah.
okay, wow, thank you.
Okay, so an overview of Oakland Health 360. As you may remember, it's a new endeavor, but it builds on a long-standing partnership that the Health Division has with Honor Community Health, really taking this big step to the next level. It also includes, which I won't talk a lot about today because it doesn't have anything to do with the funding request in here, but OLSA is another important partner in this initiative because they will be bringing navigators into our sites to assist both teams, both the Health Division and Honor clients to find resources in the community for the social determinants of health issues they're looking for. So this project is intended to be implemented in 4 phases. Really, we're lumping phase 3 and 4 together. But phase 1 is being the first phase that will be rolled out first, even before space has been built out for Honor. They would be co-locating in our clinic rooms with us for this phase, providing a full-time team that will split their hours between the north and the south office. And also during phase 1, we are expecting Honor to bring in their mobile dental bus once a week to each office, and Title X service team would come in once a week to each office. And Deb can speak more to that during her talk. This phase will be approximately 10 months to a year. It's really hard to tell because it's going to be determined by the completion of the construction of the location for Honor in both the north and south office, where they will be reconfiguring existing spaces to have exam rooms, which I'll show you in a minute. We also intend, as I said, to have also co-locating a navigator during this phase as well. In phase 2, we'll begin at the time that construction has been completed, a certificate of occupancy has been achieved, and Honor is able to move in. And there they will begin to operate in their own space. I should go back and say that we consider phase 1 to be a really important phase in that this is an opportunity to learn from each other. We'll work alongside each other really closely, and we're going to learn a lot about how can we each provide services out of our spaces and then have a seamless transition from one to the other, and how are we going to achieve that with minimal burden on the client. We want to make this as easy as possible, really barrier-free access to care. So in phase 2, once we've learned all that we've learned during phase 1, now we're going to be in separate spaces, but because we've taken these baby steps to go at this rather a slow implementation of it, we feel that we will have learned a lot and will be able to provide those seamless services in separate spaces by that time. So phase 1 and phase 2, over a 2.5-year period, Honor will implement an increasing array of healthcare services, including primary care, women's health services, Title X, and behavioral health. With service area space also will move into a more permanent location within these buildings and work alongside us as well. During phase 3 and 4, really, we will be doing really strong evaluation work to see what's working, what's not working, what do we need to shift and change, what other partners may we need to bring in to fill the gaps that we may be finding along the way. Also, public health programs and collaborations will also utilize the data that we start to share and utilize that in our communities and neighborhoods that we identify being hotspots, if you will, of need, where we can really wrap our arms around communities and neighborhoods to make a difference there and work upstream as well. So this will be welcome information that is collected from this initiative.
Would the navigator refer to specific mental health and/or substance abuse programs, or would you
That
have
would
the
be through
therapist or clinician on site to provide that service?
You know, I think, Commissioner, we're still working that through. We'll do both things. We'll follow the model that we're following right now, which is we'll do brief intervention rate on-site and do an assessment, but we're going to make referrals out to partners who do long-term counseling pieces. Our goal is to make sure that that patient's coming in for primary care, equally important that they're getting behavioral health and mental health services. So we'll be working closely with partners, but we'll start out as that originating force.
And we've
you.
already started discussions with those partners as well, and they realize that that is the intended model, and we'll be working with a number of providers in the community.
Thank you.
So then the budget. So there was a $4 million set aside in the December final report, but today we're asking for a portion of that. This is sort of divided up into two spaces, if you will. 1.7 million is the early estimate for construction costs. However, it's gone through a design process right now, and FMNO is preparing to put this out to bid. We expect those bids to be back in June, at which time we'd be coming back to ask for that funding for that build at that time. So, but for today, $2.3 million is what we have found to be Honor's startup costs, which we want to support to get them to a place of sustainability. This is a model that is utilized by the federal government, but in absence of availability of that funding, for us to see this project through, the county is investing in that startup cost. So that includes all the personnel, equipment, and supplies over the first 2+ phases. So we have a contract that's being worked out right now with a payment schedule, and that will be in that piece. So the next thing I have to show you is the floor plans that are in your packets. Can you put a pointer on that or not? So what I want to point out to you is this is South Oakland Health Center, and if you could point out the parking lot and where the front door is, I want you to know there's a little picture there of the full building, the full first floor. So the parking lot and the front door, if you can see where the front door is, Honor would be in the space immediately as you walk in.
Here's the front door up here, all the way up there. I'm not tall enough to reach it, but if you would follow this all the way up, that's the front door.
Like it's
south.
not,
We'll show it there for some reason.
Yeah, to the left of the shaded area.
If you look on,
it's on
not tall enough.
So in the bigger, you can see there that there's space there for 5 exam rooms, plus a couple of other rooms that are needed for their services. And the Oakland County Laboratory will remain in that space as well. And then for the North Oakland Health Center, it also is right inside the front door immediately to your left, that whole front area. And there's room in the north office space for 6 exam rooms in this design. So that, I'll come back in a few minutes after Deb does her part.
Yep.
Okay?
Oh, sure. Commissioner Todd.
I have some questions, if I might, Kathy, please. In 1965, when Medicaid came into being under the Great Society of Lyndon Baines Johnson, the reason we put Medicaid in was because it was felt in those times that people were stigmatized, that it was demeaning for people to have to go to a free clinic somewhere. So the idea was everybody should have health care from a qualified physician, regardless of who they were. And this is carried through, obviously, for over 60 years. Are we now reverting back to the old model where we have free clinics, which is basically what this is? I mean, if people don't have the money, they get free care, which is fine. But I'm just asking, is this the new federal model that we're reverting back to?
Yeah, we can both do it, go for it.
So Commissioner, no, it's not. I worked with Ingham County Health Department, which was one of the first counties to get one of those grants under the Lyndon B. Johnson piece. And they really have made and continue to make great strides in making sure that people understand it's not clinical. It is a health center. It is delivered by qualified health individuals. What you will hear in a little bit about being an FQHC, federally qualified health center, is that the community receives that designation where there are high pockets of poverty. And there are a couple here in Oakland County. The great thing about Oakland County is a very rich, resource-driven community with much love and leadership, but there are pockets of poverty, and you'll see them today as you've seen them right here. That designation as an FQHC, which we receive for Pontiac area in particular, but all of Oakland, allows us to see anybody in Oakland County. When we see an individual with Medicaid, we get an enhanced reimbursement that offsets the cost from seeing an individual who doesn't have doesn't have insurance. So that's the value of this. That is very different. If I have a site visit, which we've had 2 now, and I were to say the word clinic or free clinic, I'm actually reprimanded because it is a structured clinical. That's the reason why we have a chief medical officer here, reason why we have director of behavioral health services, lab services. So this model continues to enhance from back in the 60s, which is great. It just speaks to the integrity and the quality of services being delivered on that. So this money that's being requested is really the startup money from that often you'll see with federal government that may do that, and hopefully something will become available where we can apply for that and then offset the cost of this piece of it. But given that we want to start doing this right now, that is the county's level of investment.
So there is no funding, as you said, from Washington at all for this, but there has been, or there was?
There is always available at different points in times, Commissioner. So if you
Okay.
think back to how Honor has started, the challenge is we don't know when those dollars are released. But what we do know now as a federally qualified health center, when those dollars get released, and the last time was probably over 1.5 years ago, we will apply, because now we're an FQHC and those dollars become available for FQHCs to apply for.
Well, you have been an FQHC for quite some period of time, though, am I
For
not
4
correct?
years, yeah.
And did you receive previous funding for your other locations?
Yes, we do right now through the feds for those locations. Yeah.
Okay, I'll stop now, okay?
All right.
Thank you.
Go ahead.
So I want to just talk a little bit about Oakland or Honor Community Health Center. We have relationships with 16 different entities or different locations throughout Oakland County. We've started with 4 locations here in Pontiac, Auburn Hills, in Southfield with our partnerships with Easter Seals, CNS, OFS, through funding and support through the Community Mental Health Office. We're now seeing over 30,000 unduplicated patients. Believe it or not, that is less than 20% of those individuals in Oakland County that would be eligible based on either being Medicaid or uninsured individuals. So we still have a ways to go. That's the reason why we think it's a really good partnership here with the health department. We now have about 130 employees that are delivering services to individuals throughout all of those different sites. We started seeing with 4,000 patients. We're now, like I said, up over 30,000 with almost 100,000 visits that occur throughout the year with our patient population. There is some similar models to this model, but not as comprehensive as this team has put together. So when we look at other communities or other states for some leadership in this area, one of them is Denver out of Colorado. They've been doing this model actually since the 1960s. They converted and provided a very comprehensive model of care through Denver. And the other one is Ingham County, which actually started through the 60s doing direct service as well and became an FQHC probably about 15, 20 years ago. That's where I spent my time, was in Ingham County. What is unique about this partnership is the relationship that we're having with OLSHA, the relationship with the health department services, and Honor Community Health Center. You do not see those 3 entities coming together, and that is what's unique about this program, is that one is delivering the health education and the community engagement. That's not me. That is the unique role of a health department who's looking at that. I look to the health department for guidance in terms of messaging, what protocols are for disease management, for messaging in the community. I deliver that one-on-one care through our team, pieces of that, and families, and making sure that they're coming in for care. And then OLSHA brings in that really unique pieces that we all now are starting to recognize. And our other partners that we partner with, which helps to address the larger pieces of health disparities. So we all know, I know, going in to see my doctor, I'll go in, and if life is pretty rough at home, if my daughter's really sick or my family's really sick, I know that my health will go down because of that. I'm fortunate that I have a family that can surround me and friends that can surround me, get me to transportation. I've gotten 2 calls already. My dad's very sick. I have my cousin up with my dad today, taking care of my dad today. That's what families do. That's what friends do. And in our case, we're looking for OSHA to come in and support individuals who are needing extra help with looking for housing, who need assistance with transportation, emergency, all of those things that seriously impact our health status. So that, I think, is one of these unique partnerships. If I were sitting in your seat, I would be wondering, like, how are they going to sustain this? How are we going to get our money invested into this, and how do I know that we're going to get the services out? So I want to spend a little bit of time before we move on to the next phase of this, talking about indicators that I suspect and you would expect for me to report out to you and to the health department. And there are 5 of them that are really very important. I'm taking a look at and reporting out on there is designated. The first thing that we're going to do is we're going to designate this site as an FQHC site. And that's a special designation that only the federally, or only HRSA or the federal government will get. Once we designate these 2 sites, it allows us to bill and get enhanced reimbursement for services. And that is a big piece of the sustainability model, is that I get to bill out for services at a higher rate because I'm servicing a much more complex health concern. Second thing that I'm going to look to do is you're going to look to be steadily having those patients enroll with us as their primary care provider and delivery of care. So we're going to see that number going up, and we'll report out for that number. The third piece that you're going to want to know is the payer mix. So you'll get a pie chart from me, and you'll see what that looks like, and that payer mix will look like a Medicaid, uninsured, and commercial. So think about it. You know, I think Kathy talked about this commercial. We think that individuals should be able to go and receive these care at any place for it, but there's a lot of private doctors who don't take on Medicaid or uninsured individuals because it requires more time. And when it requires more time, it means that they're seeing less patients in the general commercial population, which impacts the bottom line. For me, on the other hand, you want to look at my numbers, and you want me to be seeing more Medicaid, Medicare individuals and Medicaid. And that is the piece that's really an important piece of this. And then revenue sources. So let's say, I don't know, in October there'll be a new fiscal year. There's always the chance that the feds will issue out an RFP to us and say, listen, we're going to give you $300,000 if you submit a plan that looks at increased dental access services. So we submit a plan. The feds come in and say that looks like a really good plan to serve the community. We'll give you those $300,000. Those are the opportunities as a federally qualified health center that we get that other communities don't get. We just don't know when those dollars are going to become available. So that's a little bit about the financing mechanism, a little bit about who we are, and a little bit about where we're drawing some of our expertise from in other areas.
Commissioner Kokendorfer?
Thank you very much. You know, first off, I just want to say thank you to the administration. You know, as a county commissioner, very rarely has the administration approached me to talk about proposals before they're up in committee. So I specifically want to thank Deputy County Executive Hobbs for coming forth, and that dialogue is how government is supposed to work. That doesn't mean we agree all the time, but that's how this process works. And I appreciate the comments about sustainability. You know, my understanding is, and correct me if I'm wrong, that the idea is, the hope is that after you pass through phases 1 through 4, this model becomes self-sustaining and doesn't require continued subsidies from the county. Is that correct?
You're correct. Yep.
Now, nobody's got a crystal ball here.
It'll become sustaining inside of 3 and 4.
Great. I mean, let's assume, devil's advocate, that it doesn't for unknown reasons, and that we reach the end of phase 4, and this in order to continue the program, it would require continued subsidies. And what do we do in that case?
So I'm thinking that the best way to answer that is that we are going to be looking at this really closely from day 1 onward. And we're gonna be working very closely with Honor to see who is coming in and taking advantage of those services. And we're gonna be working alongside of them, just as we have in the past, when Honor was having difficulties finding women, pregnant women to bring into the practice. And Dr. Hamadi came to us, me and George, and said, where are all the women that in Pontiac that need care? They're just not coming to us. And so our nurses that are in homes every day of the week then start funneling the women there because A, they're maybe not getting prenatal care soon enough. And now we have a provider in Pontiac that can provide those services. So at any rate, it'll be similar to that. We were able to really ramp up and help them get additional patients right away. We're gonna do that throughout this whole process. It's not gonna be a surprise at the end of the day, at the end of phase 2, and say, oh my gosh, we're nowhere near sustainability. We will have been working on that and taking care of that business long before we get there. So we're not gonna be sounding alarm at the 11th hour and saying, oh my goodness, we're about to enter this next phase, but we don't have enough funds, so we're back here at the table to ask you for that. That is not in our game plan.
Sure, no, I appreciate it. Is it possible that we'll need more funding to continue this process, this service, if things aren't going as planned?
I think that one of the things that we can do to provide some relief once they get to the area of being sustainable is to perhaps work with them on things like rent and, you know, the things that we will be providing in kind along the way during these initial phases. Maybe that can be extended out because the Health Division's paying for all that space now anyway. And this is really a service we need them to perform for us because we know that when we hand a referral to a client, they're not going to go anywhere necessarily for a while to get that high blood pressure addressed that we identified here. So we need them here to see our clients. So providing them relief like that only makes sense to me.
I appreciate it. I've got more questions, but I'll hold off for now. Thank you, Madam Chair.
Sure. Commissioner Powell?
This project is there any way, because this is a unique year for us, is there any way that due to changes that could take place in our executive or with commissioners, does that impact this project at all to where it could be any holdups or anything? Or is this like what we voted on is through the 3 years?
It's a 4-year contract.
So I'm saying like we solidified the funds, there's no, with the change of powers and control or whatever can affect this. I mean, to me, it's a great thing. I'm just talking about the politics that happened back door.
Yeah.
I'm just being honest. Y'all know I'm straightforward and I ask the questions that I need to ask.
Yeah.
So I'm just saying, like, is this something that despite a change of control, whatever, with commissioners and executive office, this clinic is gonna go, be it?
Jody will.
So we're doing a contract with them.
Okay,
We're gonna sign a contract, it'll be for 4 years, cause the 4
Okay.
phases. And because if there's a change of administration or a change in the Board of Commissioners, change of party control, whatever, that won't affect, the contract is still the legal document governing the relationship
okay,
between the parties.
thank you. And then my other question, I'll wait, y'all was still in the middle. I'm sorry, I'm sorry.
We're really right there. I just wanted to say, this is an initiative of partners. We've described 2 partners today, Honor Community Health with the Health Division and ALSA. But we intend to look under the umbrella of Oakland County government too, to see who else has services that may be really important and touches social determinants of health issues, and provide work desk space in this area so that they can see some of our clients as well and provide services. So we're just not stopping here. As I said, we've already had conversations in the community, and there's a lot of people really excited about this and would love to join the effort. Not that there would be more costs associated with it, but if we can provide them some space to work from, they can provide the staffing. It gives them another access point that will become more and more valuable to people as this program really ramps up.
Thank you. Commissioner Gershenson?
Yes, as we all know, oral hygiene is a major factor in good, healthy lifestyle. So what is the dental program that's going to be?
So the first
Presented.
phase that we'll look at is using our mobile dentistry program. So we have a mobile unit that we'll bring over and we'll schedule 1 day a week, 2 days a week. I'm not sure yet what that'll look like. But we have a mobile unit that will, our mobile dentistry program's in high demand. Our dental services are at capacity. So, you know, one of the potential things that we could always look at down the road is if there became dental grants available, you know, would we want to have an operatory here for that? But we have our mobile unit that we'll bring on, and then we'll move from there and assess from there.
Commissioner Powell?
Okay, so, when you had posted the, slide where it was, about the health professional shortage, how is that when Pontiac got 3 hospitals? How is they determining that?
This is talking about primary care providers.
Oh, okay.
And what that means, Commissioner, is that yes, there are 3 hospitals. The sad thing about in those areas is that there are no physicians or limited amount of physicians that are taking Medicaid or uninsured individuals. So the state makes that determination.
Okay.
They go through and they look at all of those things, and so that says something.
Okay, and then just to my colleagues, I am a patient of their dental program, and I think it's phenomenal, so thanks.
Thank you.
Dr. Turpin's great. Okay, and then, transportation. I had stepped out, y'all may have addressed that, but we know that that is one of our issues in the city, and what are some of the plans or discussions that y'all do have addressing the transportation issue?
So we do have a transportation plan right now, Commissioner. We use Uber. We have a health Uber contract where we will pay for health Uber. It's worked well, not phenomenal, but way better than working with the health plans on that. We also make available bus tokens as well. I think the state is really grappling with this whole transportation piece of Medicaid and getting patients in on the same day. But for us, for the most part, Uber's worked, and that's one of the things that we've put money aside for, is to get patients in for services, particularly moms with 3-4 kids. It's hard riding the bus or getting everybody in. So we work with case managers. That's where OSHA will be really very essential. They'll even be much more connected on resources than what we are. So the 3 of us coming together really I think, has a lot of potential to be systematic changes. One thing that I want to bring to your attention that just came out today that I wasn't even aware of, but the governor is creating a Medicaid Innovations Office, taking a look at addressing all of these. And darn, if that's happening, then we should be at the table leading those discussions because of the pain that we're all going through, looking at how to bring that together. Then we want to be at the table helping to shape what that innovation is. And this is innovation. I've done healthcare a long time, both on the public health side and on the FQHC primary care side and behavioral health, school health pieces. The fact that you've got 3 different systems willing to come to the table is not an easy feat. We're not naive to think that this is going to go easy. If you don't hear pain from us over the next 18 months, then you should probably be questioning yourself on what aren't they doing right. Because when you're doing something with systems, there's pain. You're looking at what isn't working, what comes to it. So that should be your first question to Kathy and I. Tell us about your pain. Tell us what pain your staff is existing.
We've made a pact that
We have.
it's going to be painful, but we're going to get along.
But that means it's good, as
Yeah.
long as we're learning from that. That should be
Exactly.
your second question, is what are you learning and what systems changes are you making to address those changes? If we don't do that, then we won't survive in the world that we're doing in healthcare as a whole. And shame on us. Shame on us for that piece of it.
Commissioner Taub?
Thank you. First, I want to commend Deb Brinson for her incredible job with her partnership with mental health. It's been a beautiful partnership, but I have a few questions, if I might, please.
Yes.
You have other locations. Do you plan on
Right.
keeping those open?
At this point in time, we do, Commissioner. This model of care and our board have been driven by going to where patients are in the community. And so those patients are CNS, our locations are CNS, Easter Seals, OFS, here, School Health. We have a number of school-based health centers, and then at Pontiac General pieces. They're all at capacity. So if we don't bring care here, I gotta be looking someplace else for care, quite frankly. And it makes sense for us to go where patients are. It makes sense for us to hook up with partners. This will be a different population. I am really committed to addressing maternal child health issues here. That is gonna be my love on this. I'm sad that we have such a high infant mortality and low birth rate here in Pontiac, and I am committed to addressing that. I'm equally committed to continuing our partnership with CMH, Easter Seals, CNS. Most of you know that I have a mother that was schizophrenic, lost her very early after 2 weeks of diagnosis because nobody took her illness serious because of her mental illness pieces, here in this county, no less. Our sickest populations, because of the comorbidity, is at CNS and Easter Seals. So what takes me to be able to see somebody, 2 patients in an hour, I'm generally 1 patient in an hour because of the complex issues going on. So at this point, I have no intention of losing or not fulfilling those obligations. Now, I am concerned about the changes that are coming out in the health in CMH, and this county should really be at the forefront of those discussions and leadership pieces because of the things that you've invested in, which will have an impact on those populations. So I don't, at this point, look at collapsing those in. They're unique sites, they have unique health populations, and I think would be detrimental to them.
You are purchasing a lot of equipment, over $2 million worth?
No,
No?
no. So that 2 million includes supplies, includes equipment, but it also includes personnel, so all of those,
Okay,
those
so
things.
I assume that you're going to have bids out for the equipment and the supplies?
Yes, we have to legally, but we're also working with the county on that as well. So yes, we
Okay.
have to.
So the estimate, you're just giving us a $2 million estimate, is that correct?
Correct. Until we get all those in, yes.
So what happens,
It's based on what they have paid though for those supplies and
Yeah.
equipment in the past. It's based on real numbers.
And on a formula, Commissioner. So the one thing I want to let you know is for an FQHC, you all are looking at us very, very closely, and the health department is looking at us very, very closely. And then I have the Georges on the board looking at it even closer than what you're looking at on a monthly basis. But then I also have the feds that are looking at this very, very closely. I send in monthly reports to the feds. They come out every 3 years. They're up for a site visit here in the next year. I guarantee that they will be in here. They send a team of 4 in. They look at the finances in and out. Our audit, we do a single audit, specifically looking at these grant dollars to make sure that they're being used appropriately and that we're not putting at risk. So all of those things, in addition to us as a staff looking at it very closely, help us give those numbers. But there is a formula that we use that HRSA approves and has served us very well in terms of what the average supply is for how many visits or users in there. And we'll watch that very, very closely. If we're off base on that, we're gonna know that quickly and we're gonna make adjustments on that.
may I continue?
Sure.
Okay, Medicaid, and I have a concern about this, and/or Healthy Michigan.
Yep.
I find I just can't get my arms around why somebody would not have either. I mean, obviously, I understand why people don't get insurance with their jobs. I get that part.
Yeah.
Okay, particularly if they're working entry-level jobs.
Yeah.
But why don't we have everybody on one of those 2 things? They would have to qualify if they're coming into your clinics.
They do, but there are unique circumstances in some of those situations. So Healthy Michigan pieces, we work, in both of them, it's the same application. I think, Commissioner, what I've seen happen over the last 2 years is that there was an easier way to get on health insurance versus the proofs. And so now there's a lot more proofs coming in that an individual has to bring in, and that makes it much more cumbersome to do. So that is one. Two is you have this churn that happens. So if you think back to about 15 years ago, there was a really big concern, and we call it churn. Individuals who get on health insurance and then move off because they get a job and just enough to put them over the edge, and so now they're off for that month. Now they gotta come back and they've gotta bring the proofs
Yeah.
all over again. So I think that's part of what you're seeing with that. For sure, there is no child that should not have health insurance. And so we work diligently to make sure that individuals don't have health insurance. But then the last
They
one,
don't? You mean
that they do have health insurance. But then the last one I want you to think about is if I am mild to moderate individual or if I'm an individual with mild to moderate mental health issues, it is such an energy to get up and to go and coordinate and get in for those services and bring everything in, that you start to see that reflection in terms of health insurance not covering those individuals because they don't know how to organize. They're so depressed, or there's the anxiety of going in and organizing is. And so that is what's unique about this partnership, is that there will be 3 of us that will be able to help those individuals. So we're gonna wanna take a look at that payer mix. But your other payer mix that's increasing here is your Medicare population in this community. When I first started here, 5% of our Medicare population was Medicaid or Medicare in our practice. We're now up to almost 15% in our practice with Medicare. So you're seeing that shift happen there.
I have more questions, but. Well, Commissioner Kokendorfer had a question also.
Sure, thank you. Yeah, I'm looking through the resolution. It says Oakland County will reimburse Honor for all startup costs. And then there's an estimate of the 2.3 million, give or take. Is there a cap?
That's not to exceed.
It's a not to exceed,
Yeah.
okay, because the resolution,
It's
I
in the
understand we're
contract.
appropriating that amount, but it'd be helpful to see, to not exceed, it'd be helpful. This also,
If we could just, in the contract, it will be a not to exceed amount.
Good.
That the contract, actually a draft of it, we're working on it and it has it in there. So we won't be obligated to pay anything more than is appropriated through this resolution.
I mean, that's great to hear, because one of the questions I have, I know this resolution says that the agreement will come back to be received and filed, but will this committee, will the board have a chance to vote on the actual agreement, or no, is this resolution it? It's,
I'll just jump up real quick.
From a legal point of view, a lawyer's point of view, I'll defer to Moody though.
So we're working with Chris Ward at this moment to kind of work out the process of how that contract will come back to the board. I would say that the administration, we're very open and transparent about, this contract. So to be very honest, I have no hesitation of bringing this back before the board, but I think that Chris is working with Sean Carlson in our office as an extension of the conversations from the budget conversations in terms of how contracts come back before the board. So, short answer, yes, we're still working on that piece. But I think the board will see this contract come back before. I'm not sure if it's the entire board or if it's the finance committee, but we're working on it.
Can I just add one more thing too, just so everybody, I'm sorry, Rudy, but we have an existing contract with Honor. They provide healthcare services to Children's Village. So these services will be a change order to that existing contract. So all of our liability protections, insurance, all that will be in our standard contract.
sure
So
enough.
this contract's gonna be really short. I mean, it's maybe 5 pages at most, because it's just gonna be the scope of services and any amendments to insurance.
The
that we
payment
need.
schedule.
And the payment schedule.
So I appreciate that, yeah, as also an
Yeah.
attorney, I get nervous about approving
Yeah.
something without, even if it's a 5-page contract,
Yeah,
I get a little
no.
nervous about it. So I do appreciate that. And then my other question was, this says that we'll get a separate resolution later this year on the capital improvement costs
Correct.
that are estimated to be 1.7.
Yes.
And I think those are out for design right now, I think
Yeah.
you may have said. So it may be less and maybe more than 1.7.
I think we're.
I think 1.7 was the very, very high end.
Yeah, I mean,
Art does a really good job of kind of setting, you know, the bar way up here and then kind of under delivering, so.
I like
I
that.
shouldn't say under delivering, I shouldn't say that.
Yeah.
Under budget.
Right, right. I mean, it makes me a little anxious without knowing that hard number.
They did
Wait,
they did
yeah.
some good estimations, and they
Yeah.
built in an enormous contingency and elevated those numbers, and I think they feel pretty confident that it will come in under that.
Is there a downside to waiting until we have that hard number other than we're losing time?
Well, I think that we really want to get underway with phase one before the construction, because we really want to work through a lot of things before they're moving out into their separate space.
Thank you very much.
Sure, okay, final questions by Commissioner Taub, followed by Commissioner Powell. And then we're
Okay.
voting.
Are you still getting the $1 million annually from community mental health?
We are for CNS, for Easter Seals, and for OFS, those 3 locations.
Okay, are you going to be asking them for money for this location?
For this location, I probably will not ask for this location. It's a different population. Commissioner, that's the reason why I feel I'm pretty comfortable in that I see, when we look at your patient population here, it's not a CMH population. It's a general population, a women's and children's focus. That's the reason why I'm really excited about the opportunity to kind of dive deep in and take a look at the infant mortality and the birth weight. If you had a really high population with serious mental illness, I think it would be a fair conversation that we all could have with CMH, but it is a very different population than I see from Easter Seals, CNS, and even from OFS on that.
Okay, and who provides the malpractice for your physicians?
So we do. We provide the malpractice twofold. We have a gap insurance program, but because we're now an FQHC, we're FTCA certified.
What does
covered.
that mean?
That means that the federal government, the Federal Tort Claim Act, comes in and provides coverage for all of our physicians. And that practice, or that coverage, will be covered here at this site too. And that is a very good thing, very good thing.
Okay, so when that physician sees a pregnant woman in the clinic and then delivers the baby somewhere, some hospital, we would have to assume, does that malpractice carry through to the hospital, or is that another component?
No, that's another component, because the hospital and their hospitalists do the delivery of the babies, unless we're there as part of it. But for the most part, the docs in the hospitals are. So St. Joe's, we have an agreement with St. Joe's and their physicians to do the delivery for our babies. The OB services are covered under us.
Okay.
And so if there was an issue with the OB services, providing those services up to the hospital stay, then our FTCA coverage would cover it.
So a young woman would see, or any woman who's pregnant, would see one doctor at the clinic, okay, and another doctor to deliver her baby?
No, we have that doctor coming in.
Oh,
She
you
gets 2, yeah. So, and Dr. Hamani, if I'm not explaining this correctly, please feel free to join in. But she gets 2 docs. So she gets the doctor from St. Joe's that comes in, and they actually practice, and so they get to meet Debbie Brinson. I'll see you up on the floor up there. But also, our doctor is right there with them, giving the care as well. Our residents are there. So remember, we have a residency program that will probably extend over here for OB services.
Okay, who are members of your board besides George? I know George.
So Philip Henry is our board chair, and he is from Fifth Third Bank. He sends his apologies. He couldn't get here, but he'll be here on Wednesday and next week. Oh, boy, now I gotta go by memory on everybody. So it's
Or why
George-
don't you just send it to us?
I'll send
okay?
it to you.
That would be a very good thing, thank you.
Deb Giroux from,
No, don't, yeah.
okay, I'll
Yeah,
send you.
okay.
Yep.
Why don't you just send it to Kathy? She'll be happy, I'm sure, to email it to us. And who's your registered agent?
Matt Danaskis.
Okay.
Yes.
Thank you.
You're welcome.
Thank you,
Commissioner-
Madam Chair.
Thank you. Commissioner Powell?
I'll just get her number. I'm gonna set up a meeting with you to help you with Pontiac, so.
Thank
we'll
you
talk
very
offline.
much.
Thank you.
Okay, appreciate it,
Cause I know
Commissioner.
you're ready to go.
Thank you. You are correct.
Yeah.
All right. Then seeing no other questions, we'll have a roll call, please.
Gershenson,
Yes.
Todd,
No.
Nelson,
Yes.
Powell,
Yes.
Kokendorfer,
No.
Boobs,
Yes.
motion carries.
Motion is carried. Is there any other business to come before this committee? Then without further ado, at 12:10, a 60-minute meeting, I'm proud of everybody. We are